good evening, everybody. After 3 consecutive modules on two each on headache, dementia, and movement disorders, we thought that it would be appropriate to have a bit of a revision on what we learned, and with that purpose, and so the lectures, in addition to everything, we thought made the whole session extremely intense. So today, and a lot of things to take for the students. So today we thought we would deliver a quiz. It will revise what you learned in the last couple of modules, the 2 modules which are on headache. And also, it will be on a slightly lighter scale, I hope so. Dr. Amit Pandey has made it a bit light, or maybe it's a bit heavy. Let us see how it is. So, before I begin, before Amit Pandey begins, instructions to all of you. This is a quiz wherein you are going to answer on an interface called Slido. Those of you who have logged in on a laptop, then you will see the presentation on a laptop. In addition to that, you need to open Slido on mobile, either through your Google Chrome browser, or you can download the Slido app, and you have to see the question on the laptop and answer on the mobile on the Slido. If you are only watching on mobile, then you will have to alternate between the browser of the Zoom and the browser of the Slido. So in the next few minutes, we are going to begin. So get ready with the technical requirements to the quiz. And another instruction is that you will see the question twice. First, you will see on a PowerPoint-like slide, and that will be displayed only for a few seconds, and then Dr. Pandey will move on to the actual Slido portion of the slide, where again you will see the options. Before he goes on to Slido, you will see an instruction called get ready, and then the Slido will display the same options, and as soon as the Slido does that, there will be a horizontal bar which under the question which you will find sliding. You have to start voting then and there, and your votes will be taken, and then once that time frame is finished, which will be around 20 to 30 seconds, and then onwards Dr. Pandey will give an explanation on the question as to why it was important, the right answers and the wrong answers, and that's the way it runs. And Slido code, yeah, so Slido code Amit Pandey will tell you in a second. What is it?
5450.
5450. I will type it somewhere. 5450.
Okay. They'll be able to see it, sir. Once we start,
they will be able to see. So that's it. I think that's all what I wanted to say. And on Thursday, we are going to have clinical aspects, a couple of signs, movements, and limits, and that will be followed by a quiz on cerebellum Susvirkar. So you long for that as well. But now, as of now, I will request Dr. Amit Pandey to begin his quiz. So off to you, Amit.
Okay. Thank you so much, sir. Good evening, all of you. I would like to thank the fine forum, especially Dr. Pujari sir, Kothari sir, as well as Zubairkar sir, who have helped me prepare this quiz. So this quiz is just a revision, as sir has said, about the headache module. So we start quickly. I'll share the screen.
Good.
So, sir, I'm sharing my screen now. You can see my screen, right? Yeah. You'll see my screen?
Yes, it's coming. Yeah, we can see.
Yes.
Okay. So
you will have to put it in full screen mode, I believe. This is yeah. Okay. Perfect.
You can see this?
Yes.
So yes. So the code for the Slido is 5450. And you can see this code over here. So we'll start with the quiz. So as sir has already told, the PPT slide would be shown first, and after that the Slido slide would start. So we'll start with a dummy question first. First of all, let me give a disclaimer that the answers are the best preferred options backed with data. Opinions may differ in practice, and pardon me for my mistakes because this is the first time I'm conducting quiz. Suggestions are always welcome. So without further ado, we'll start with a dummy question. So on Slido, you have to just type what is the most common type of headache that a neurologist has. So this is an open response question. I just want you to type what is the most common type of headache that a neurologist has. So as you type, you'll see. You have to type on, migraine, tension type headache. We all neurologists believe that we have migraine first of all the headaches, never the other types. Yes, so we are ready and I think we are good to go. So with this, we will start our first question if everybody's done. Yes, we have got the answer of migraine. Yeah, we'll move on to the next question. So be ready. The first question will be shown in the form of the PPT slide first. So question 1, which of the following statements is false about spontaneous intracranial hypotension? First, it's commonly seen in patients with hypermobile joint disorders. Postdural puncture hypotension is a SIH. It is associated with osteophytes, spurs, and meningeal diverticula. Can be seen in long-standing secondary intracranial hypertension. So you're ready to join the quiz? These all people have joined. And your time starts now. These are your options. So you have to vote now. You can select any of the options and on your Slido app. So which of the following statements is false? Yes. So maximum of you have voted correctly. So you've been attentive during the lectures. So postdural puncture hypotension is SIH is a false statement. Why is it? Because postdural puncture headache is not spontaneous. The site of affection is different. It is in lumbar location versus the cervical, which is most commonly seen. And the mechanism of headache is different. There is change in the craniospinal elasticity and increased lumbar compliance relative to intracranial compliance that causes acute intracranial venodilation in upright position. This is the thing that causes headache. Okay, so hope many of you have got this correct and we move on to the next question. So which monoclonal antibody is fully human? The first one is eptinezumab, adalimumab, fremanezumab, or galcanezumab. The slide comes up. Get ready for it. So which monoclonal antibody is fully human? This can be an easy one if you read the options correctly. So wow, it was a easy one. So adalimumab. So you've got the right option. So something about adalimumab. Since adalimumab is a fully humanized monoclonal antibody, it shows marked species selectivity and exhibits about 5,000-fold higher affinity for the human receptors. Binding of this drug to its receptor is 20-fold greater than the CGRP receptor antagonist telgagepant. It is also the one monoclonal antibody which binds to the CGRP receptor. Others bind to the ligand. Important point here is it is effective in prevention of migraine in patients with several previous preventive medication failures. So this is an important point. So whenever you don't have any option, you can use adalimumab. It is approved. And to go back and revise the nomenclature, here you can see whenever there is only U in the monoclonal antibodies, it denotes that is of human origin. Others like Z are chimeric, Zizou are chimeric humanized, and the Zoo is only humanized. Okay. So yes, many of you have got this right. And so we move on to the next question. Something about RCVS. So what is not included in the diagnostic criteria of reversible cerebral vasoconstriction syndrome? Thunderclap headaches at onset, a uniphasic disease, course with no new symptoms after 1 month of onset, normal or near normal CSF analysis, or multifocal cerebral vasoconstriction demonstrated only on catheter angiography. So what is not included? So get ready. This is your Slido quiz. So these are your options. What is not included in the diagnostic criteria of RCVS? Wow. So you all have 73% of you have got the right answer. It is multifocal cerebral vasoconstriction. So this is the diagnostic criteria for reversible cerebral vasoconstriction syndrome. Patient needs to have acute and severe headache, which is often thunderclap, with or without focal deficits or seizures. It is uniphasic in course without new symptoms more than 1 month after clinical onset. This is your answer. Segmental vasoconstriction of cerebral arteries should be shown by indirect, that is magnetic resonance, or CT, or direct catheter angiography. It is not only dependent on the diagnosis by direct catheter angiography. There should be no evidence of aneurysmal subarachnoid hemorrhage, near or near normal CSF, and complete or substantial normalization of artery shown by follow-up with indirect or direct angiography within 12 weeks of clinical onset. So you can read this article by Anne Ducros from Lancet Neurology, solve your queries, and read more about RCVS. Moving on to the next question, question number 4. So serotonin during migraine attack is released by which of the following? Is it platelets, the periaqueductal gray matter, both of the above, or none of the above? So this is your Slido slide. Get ready to vote on your mobile phones. So serotonin during migraine attack is released by which of the following? Yeah, whenever we were taught in school, whenever there is an option of both of the above, use both of the above, and it indeed is the correct answer. So what happens? The neuropeptides that are released in migraine, serotonin, which is released by the platelets and periaqueductal gray matter, it has got a role in nociception, and it is increased during the migraine attack. CGRP, as we know, plays a role in vasodilation, endothelial damage, plasma leakage, and platelet aggregation. And nitric oxide and substance P they activate pain fibers, that is A, delta, and C fibers, and are responsible for sensitization of trigeminal afferents. So those who have marked platelets and periaqueductal both, you're absolutely right. Good. The next question, question number 5. The criteria for spontaneous intracranial hypotension are all except the demonstration of spinal CSF leak, MRI signs of intracranial hypotension, CSF pressure of less than 90 millimeters of water, and improvement in symptoms of after epidural blood patch. So this is your Slido slide. Get ready to answer on your mobile app. The criteria for spontaneous intracranial hypotension are all except. Good. 65% of you have answered it correctly. It indeed is not less than 90. The answer is the diagnostic criteria involves low opening pressure less than 60 millimeters of water. So you need to demonstrate a CSF leak There should be cranial MRI, changes of intracranial hypotension, a subdural fluid collection, enhancement of pachymeninges or sagging of the brain, and presence of at least one of the following, that is low opening pressure, spinal meningeal diverticulum, or improvement of symptom after epidural blood patching, or the presence of all of the following, or at least two if typical orthostatic headaches are present, a low opening pressure, spinal meningeal symptoms, and improvement of symptoms after epidural blood patching. Good. Moving on. Question number 6. So what is the duration for episode of cluster headaches? 1. Is it 15 seconds to 180 minutes? Is it 15 seconds to 15 minutes? 4 hours to 72 hours? Or 72 hours to 7 days? Your slider side is up. Start voting. What is the duration for episode of cluster headaches? Is it 15 seconds to 180 minutes? Good. Everybody's reading a lot. So 86% of you have answered correctly. So differential diagnosis of short-lasting headaches. You can clearly see that cluster headaches last from 15 to 180 minutes. Trigeminal neuralgia is the shortest duration, less than 1 second. And others like paroxysmal hemicrania lie somewhere between 2 to 45 minutes. SUMC lies between 15 to 120 seconds. And a hypnic headache lies for 15 to 30 minutes. So longest disorder with headaches is cluster headache, and the shortest one is trigeminal neuralgia. Moving on. Question 7. Familial hemiplegic migraine type 1 is caused due to mutation of which gene? Is the gene ATP1A2 located on 1q, SCN1A located on 2q, CACNA1A gene located on 19, or ENOCH3 gene located on chromosome 90. Be ready with your mobile phones. Here you go. So familial hemiplegic migraine type 1. Yeah, absolutely right. The answer is CACNA1A gene. So you can see that familial hemiplegic migraine is associated with CACNA1A, and it is also associated with episodic ataxia, minor head trauma, prolonged coma. Familial hemiplegic migraine type 2 gene is the ATP1A2 gene and is associated with epilepsy. And FHM3 is associated with the SCN1A gene. Okay, so it is a. So moving on to the next question. Question number 8. I hope you are getting all your answers right. It's simple till now, nahin? The best test for localizing site for slow leaks in spontaneous intracranial hypotension is it a dynamic CT myelography, a delayed MRI myelography, radionuclide scintigraphy, digital subtraction myelography? Get ready with the phones. The best test for localizing site for slow leaks in SIH. Whoa, we have got a mixed response, but yes, majority have got it right. It is delayed MRI myelography. So you have to remember this algorithm. This is taken from the Continuum 2015 headache. Whenever you suspect a CSF leak, you need a head MRI, contrast enhancement, and a spinal MRI. If it is positive, you do a lumbar epidural blood patch, no or adequate relief, repeat the EPB at lumbar or bilevel, do a CT myelography and identify the site of leak. If it is identified, then do a targeted epidural blood patch. For a rapid flow leak, you need to do a dynamic CT myelography or its variants, that is the digital subtraction myelography. For slow flow leaks, you need a delayed CT myelography and or gadolinium myelography, that is delayed MRI myelography. Okay, so whenever the MRI and spinal head MRI and spinal MRI are negative, they should, and if your clinical index of suspicion is high, you do a radioisotope cysternography to locate the site of the leak. It only gives you a rough idea, and if it is positive, repeat this procedure. Okay, so I hope this solves your query. For slow flow leaks, do a gadolinium myelography, delayed. Next question. So migraine is a risk factor for which of the following pregnancy associated conditions? Is it oligohydramnios, pituitary apoplexy, placenta accreta, preeclampsia, or premature rupture of membranes? Be ready. Migraine is a risk factor for which of the following pregnancy associated conditions? Wow. So 56% of you have got it right. It is preeclampsia. So this is from the up-to-date migraine and pregnancy outcome. So studies evaluating pregnancy outcome in migraineurs generally conclude that migraines treated or untreated are associated with an increased prevalence of hypertensive disorders of pregnancy. So miscarriage, preterm delivery, and low birth weight were modestly increased, and there was no increase in growth restriction or congenital anomalies. So of note, women with migraines had higher preconception levels of hypertension, depression, and asthma. So what outcome it has on pregnancy is that the females become hypertensive or suffer from preeclampsia and eclampsia. So remember this. Okay, moving on. Next question. Which are the common phenotypes in new daily persistent headaches? Are they chronic migraine phenotypes, chronic tension types? There is no specific phenotype, or both chronic migraine and chronic tension type headaches are seen in new daily persistent headaches. Be ready with your Slido app. Your question goes live now. The time starts now. So which are common phenotypes in new daily persistent headaches? Good. Both chronic migraine and chronic TDH. Yes. So the International Classification of Headache Disorders, the third edition, published in 2018, describes NDPH as a persistent and continuous headache with a clearly remembered onset. The pain lacks characteristic features and may be migraine-like or tension type-like or have elements of both. Okay. So the following are the ICHD-3 diagnostic criteria for NDPH. Persistent headache which should be fulfilling, distinct and clearly remembered onset with pain becoming continuous and unremitting within 24 hours, present for longer than 3 months, and the disorder should not better accounted by any other ICHD-3 diagnosis. Okay, so remember NDPH will have both types of headaches, migraine-like or tension type-like or elements of both. Okay, moving on to the next question, that is question number 11. So areas of nervous system involved in pathophysiology of trigeminal autonomic cephalalgias include all except the trigeminal-vascular system, posterior hypothalamus, the brain cortices, trigeminal autonomic nervous system. Be ready. Your time starts now. Areas of nervous system involved in pathophysiology of TACs include all except. This is an easy one. Good. So majority of you have answered, 74% of you have answered brain cortices. Yes, it is not involved in the pathophysiology. You have to remember this diagram in which the important centers are given. The trigeminal nucleus is important for perception of pain. It is part of trigeminal-vascular complex, connects to the pain neuromatrix, and the molecules released are CGRP, and it is a target system for triptans. The hypothalamus, the molecule released is melatonin. It is a target system for verapamil and lithium. And the cranial autonomic symptoms are mostly because of the superior salivatory nucleus. It connects to the sphenopalatine ganglion, and molecules are vasoactive intestinal polypeptide and target system for oxygen. Okay, so three systems: the trigeminal nucleus, hypothalamus, and the superior salivatory nucleus. You have to remember these. Okay, the cortex is nowhere involved. Moving on to the next question. All drugs are useful in RCVS except steroids, nimodipine, IV nicardipine, or analgesics. You're ready with your Slido? Your time starts now. So all these drugs are useful in RCVS except. Oh, very good. Majority of you answered correctly. Steroids. So glucocorticoid associated worsening in RCVS. So majority of studies have found that glucocorticoid treatment proved to be an independent predictor of clinical imaging and angiographic worsening and poor outcome. There were no significant differences in the baseline brain lesions and angiographic abnormalities between glucocorticoid treated and untreated patients. So whenever patients with RCVS are at risk of worsening, they can be identified on the basis of baseline features, and iatrogenic factors such as glucocorticoid exposure may contribute to their worsening. So glucocorticoids are not used in the treatment of RCVS. Good job. Moving on to the next question. Which ergot preparation has American Headache Society level A recommendation for acute treatment? I repeat, which ergot preparation has American Headache Society level A recommendation for acute treatment? Is it IV or IM dihydroergotamine 1 milligram, subcutaneous dihydroergotamine 1 milligram, intranasal dihydroergotamine 2 milligrams, ergotamine tablets 1 to 2 milligram? So get ready, use your app, answer now. These are your 4 options. The question is only on ergotamines. Which ergot preparation has AHS level A recommendation? Yes, first time I'm seeing a good split, so nobody knows the answer. Yeah, the answer is intranasal dihydroergotamine 2 milligram. So it is approved by the American Headache Society as level A evidence. The subcutaneous IV and IM forms are level B. So recommendation for use in episodic migraine is moderate, according to the Canadian Headache Society. So according to AHS was the question. So dihydroergotamine intranasally has got a level A recommendation. So this is from the latest edition, 2018 Continuum Headache Edition, acute treatment of migraine. Next question.
Amit.
Yes, sir.
Dr. Amit Pandey.
Yes, sir.
There are a couple of attendees who are answering. One is answering on the Q&A, Keval.
Okay.
And Dr. Bindu is answering on chat.
Okay.
So Dr. Bindu and Dr. Keval, you have to open Slido on your mobile and key in the 5450 code and then answer on Slido. Okay. So neither on Q&A nor on chat. I think you can carry on.
Okay, sir. So question number 14. Dose and duration of indomethacin trial considering alternative diagnosis in paroxysmal hemicrania is. So you have, how long can you give indomethacin, for what dose and how long? This is the question. Dose and duration of indomethacin trial considering alternative diagnosis is it 75 milligram 3 times a day for 2 weeks, 75 milligram 3 times a day for 6 weeks, 25 milligram 3 times a day for 2 weeks, or 25 milligram 3 times a day for 6 weeks. So you have to choose your best response. Get ready with your Slido app. Keval, Dr. Keval and Dr. Bindu. 5450 is the code. Yes, your time starts now. How long would you want to continue indomethacin to consider alternative diagnosis in paroxysmal hemicrania? Oh, absolutely right. Absolutely right. 31% have got it wrong. 50% have got it right. So yes. So it shares features with TACs. Management starts with an indomethacin trial, and by definition, patients with hemicrania continua should have a dramatic response. Indomethacin treatment is the same as that mentioned above for paroxysmal hemicrania, with a trial up to 75 milligram 3 times a day for 1 to 2 weeks with use of gastroprotective agents. Okay. You also need to note this: remissions have been reported in hemicrania continua, and withdrawal of indomethacin should be considered every 6 months. If the symptoms are to return, they will generally reappear 12 hours to 2 weeks after indomethacin is stopped. So whatever holds true for hemicrania continua holds true for paroxysmal hemicrania. You need to continue it for 75 milligram 3 times a day for 1 to 2 weeks, and then give up and consider alternative diagnosis if the patient's pain does not subside. Okay. The classical feature of these disorders, hemicrania continua and paroxysmal hemicrania, is it's completely responsive to indomethacin. I hope you've got this. Moving on to the next question. Which of the following is the best line of management for a 30-year-old obese lady with this perimetry finding? See in the next slide, but no headache, vomiting, or diplopia. No headache, vomiting, or diplopia. So this is a perimetry. So if you have seen the perimetry, I'll go back. So which of the following is the best line of management for this lady who has got these perimetry findings but no headache, no vomiting, or diplopia? Is it serial CSF drainage? Is this medical management and dietary therapy only? Shunt surgery? Optic nerve sheath fenestration? Your time starts now. Which of the following is the best line of management for this 30-year-old? Absolutely. Perfect. Optic nerve sheath fenestration. Yes, you remember this from Dr. Dhruv Batra's slide. How to choose the best surgical option. If there is papilledema and vision loss, which this female has, without other symptoms, no headache, no diplopia, no nausea, no vomiting, and there are signs of increased intracranial pressure, then choose optic nerve sheath fenestration. If there are severe symptoms like headache, papilledema with vision loss and raised ICP, you choose CSF shunting. So when severe symptoms are present, you use CSF shunting with vision loss. When no symptoms are present and there is only vision loss and papilledema, use optic nerve sheath fenestration. Okay, this is the article in which it's given, the Journal of Neuro-Ophthalmology, 2013. Moving on to the next question. Question number 16. According to the neurogenic theory of migraine, cortical spreading depression is initiated by which mechanisms? According to the neurogenic theory, cortical spreading depression is initiated by which mechanisms? Is it focal energy alterations, spontaneous depolarization, neuronal hyperexcitability, loss of gating on NMDA receptor? Okay, get ready on the Slido. Your time starts now. Cortical spreading depression is initiated by which of these mechanisms? This is a difficult one. Good, everybody thinks that it is spontaneous depolarization, and I am actually happy that you have got it wrong. So the answer is focal energy alterations. This is from Dr. Parasdevkar sir's talk. So neurogenic theory, there is focal energy alteration leading to an area of oligoemia. Coupled with magnesium deficiency and uncoupling of mitochondrial enzymes, this leads to neuronal hyperexcitability, spreading activations, which cause loss of gating of NMDA receptors, there is spontaneous depolarization, and there is cortical spreading depression. There is decreased metabolic need, decreased blood flow. So you can get this reference, distinctive anatomical and physiological features of migraine aura revealed by 18 years of recording from Brain 2013. So focal energy alterations lead to oligoemia, and this is the initiation for CSD, that is cortical spreading depression. I'm sorry. Okay, moving ahead. Question 17. All is false about epidural blood patch, except the response to epidural blood patch is not a diagnostic criteria for SIH. It is a sure shot technique with 95% success rate. Blood has to be injected at the site of leak. Giving acetazolamide before procedure may allow you to infuse more volume of blood intrathecally. I repeat the question. All is false about epidural blood patch, except. Here we go. Your time starts now. So what is false about epidural blood patch, except? Wow. So when you twist the question, everybody falters. You see, there are two negatives. All is false except means what is true. So what should be true in this? The true answer is giving acetazolamide before procedure may allow you to infuse more volume of blood intrathecally. Okay. So you know that the low opening pressure of 60 millimeters, spinal meningeal diverticulum, improvement of symptom after epidural blood patching is the criteria, and MRI signs need to be present. But the success rate of EPB is only 30%. It has to be repeated 3 to 4 times. And it may be done in lumbar region, and then you put the patient in a Trendelenburg position. And relief of headaches is diagnostic. So it is not a sure shot technique. It has to be repeated many times. And it is not to be given at the site of the leak. You can give it in the lumbar region and give the position accordingly. Okay? Hope this solves the doubt. Identify the false statement in this next question, question number 18. Which is the false statement? Frovatriptan has longest half-life time about 24 hours. Combinations of triptan with NSAIDs are better than triptans alone. Sumatriptan can be safely given in patients with MI and stroke. Maximum dose of rizatriptan when given with beta blockers is 5 mg. So which of these is false? Your time will start now. So you need to identify the false statement. Read frovatriptan has longest half-life time of about 24 hours. This is fairly easy. Yeah, I knew it is very easy. So sumatriptan can be given safely in patients with MI and stroke is completely false. So these are practice guideline updates from the acute treatment of migraine in children, adolescents, and the old age people. So according to FDA, triptans are contraindicated in patients with history of cardiovascular disease, including stroke, transient ischemic attacks, myocardial infarction, peripheral vascular disease, ischemic bowel disease, coronary vasospasm, and Brinsmetal's angina. Triptans are also contraindicated in patients with cardiac accessory conduction pathway disorders like the WPW syndrome. So, okay. So level A recommendation, clinicians must not prescribe triptans to those with a history of ischemic vascular disease or accessory conduction pathways. Okay. As is the using of triptans may aggravate these conditions and increase the morbidity and mortality. I hope you got it right, all of you. Question number 19. A 63-year-old woman has no comorbid illness and has got a peculiar history of being awakened by a gunshot-like sound at night. There is no actual headache and no focal neurology. Examination is normal. What is the mutation responsible for this condition? Is it CACNA1A, CHRNA2, CLCN1, GABRG1, or SCN4A? First, you need to know what is this condition. Then you will be able to answer this. So 63-year-old women, no comorbid illness, awakened by a gunshot-like sound. So your options will be displayed now. Go on your Slido and click the right option. Women with no comorbid illness, 6-month history of being awakened by gunshot-like sound. This is very, very transient. The examination is normal. Good. All of you, 19% of you have got the right answer. The rest of you, here is the explanation. So this presentation is consistent with a condition known as exploding head syndrome. It is actually a sleep disorder and is commonly confused for a headache disorder. There is brief perception of loud explosive noise occurring in sleep transition. Frequency can be one attack over several days to many attacks in a single night. It is only fleeting. It lasts for only 1 second or 2 seconds. It is associated with abrupt arousal and patients are often fearful. So it is associated with a mutation on CACNA1A mutation on chromosome 19. So it may be associated with other visual phenomenon, tachycardia, sweating, and rarely myoclonic jerks. It is a self-limiting condition, may go away on its own. It doesn't need any specific treatment. Okay, we go with the next question. All is true about MRI findings in spontaneous intracranial hypotension, except venous distension sign is seen due to increased venous volume. There is pituitary hyperemia or enlargement. The pachymeningeal enhancement is seen indefinitely, and there may be associated cerebral venous sinus thrombosis. So what is true about MRI findings in SIH, except? Here are your Slido options, and your time starts now. Good, a split, but the majority of you have got it right. The pachymeningeal enhancement is not seen indefinitely. So it resolves with duration. The increased blood volume, which is known as the venous distension sign, is seen because of increased blood volume. It may be occasionally associated with CVST. There is enlargement of pituitary due to hyperemia. Subdural effusion can be seen. There may be cerebral edema and reduced CSF volume. The quantitative signs for Brownie points are these: mammapontine distance less than 5.5 millimeters, pontomesencephalic angle less than 50 degrees, and interpeduncular angle less than 40.5 degrees. So the pachymeningeal enhancement, it resolves with duration. Okay. Question number 21. We are coming to the business end of this quiz. So a 34-year-old female who has had severe headache, which started with left-sided weakness, lasted for 10 minutes, and was followed by numbness for 10 minutes. It was associated with nausea and vomiting, and is right-sided in nature and is pulsating. She has had a similar headache history in past and a family history of similar headaches. What is the appropriate drug of choice for her acute headache? So a female with left-sided weakness for 10 minutes, followed by numbness for 10 minutes, nausea, vomiting, family history, and right-sided headache. The appropriate drug of choice for her acute headache. So is it sumatriptan, ibuprofen, lamotrigine, rizatriptan, or dihydroergotamine? So which of these would you give her? Lamotrigine, ibuprofen, sumatriptan, rizatriptan. Okay, so let's go. The right answer is ibuprofen. We are asking what is the appropriate drug for her acute headache. We are not talking about chronic headaches. We're not asking for a prophylaxis. So this is a case of familial hemiplegic migraine. The acute recommended treatment are acetaminophen and ibuprofen. Controversy about use of triptans in cases of hemiplegic migraines and basilar migraines because they are vasoconstrictive in nature and they may exacerbate the morbidity. This is what is thought about. Lamotrigine can be used as a prophylactic and not in acute treatments. So the answer here is ibuprofen. Okay, I hope you get it. Question number 22. So this is a multiple choice question. Treatment options in refractory cluster headache include all except, is it spinopandletine ganglion stimulation, occipital nerve stimulation, a deep brain stimulation, vagal nerve stimulation. So what are the treatment options in refractory cluster headache except? So you have to choose the wrong ones. Your time starts now. So yes, both deep brain stimulation and vagal nerve stimulation are not approved. In fact, deep brain stimulation is associated with unfavorable responses in cases of treatment of refractory cluster headaches. So spinopandletine ganglion stimulation has got level B. Occipital nerve stimulation is used. It's not got unfavorable responses, but hypothalamic deep brain stimulation is unfavorable, and VNS or vagal nerve stimulation has never been tried. Okay, so spinopandletine ganglion has got a level B. Moving ahead, which statement is false regarding pregnancy with migraine? Acetaminophen during pregnancy is associated with ADHD in children. Metoclopramide and sumatriptan are safe. Triptans cause increased risk of preeclampsia. And NSAIDs are safe in the first and third trimester. So which of this statement is false? Okay. You can go on the Slido app and start voting now. Which is the false statement? Metoclopramide. Okay, majority of you have got it right. I'll just explain it to you. So drug of choice is always acetaminophen in cases of pregnancy and migraine. If headache is not relieved, can combine metoclopramide and caffeine. Caffeine up to 200 milligram is devoid of any adverse effects in pregnancy. So acetaminophen is the drug of choice. Second line options are NSAIDs and aspirin, but use in the first trimester may lead to associated with congenital anomalies. In the last trimester, it may close the ductus arteriosus, causing pulmonary hypertension and oligohydramnios. The third tier options are opioids, but long-term use is ill-advised in view of addiction potential, withdrawal, nausea, vomiting, constipation, and risk of CNS malformations. Triptans may decrease fetal cerebral blood flow and cause uteroplacental insufficiency. So that's why the option of using NSAIDs in first and third trimester being safe is wrong. It cannot be used in first and third trimester. Okay, moving ahead. What is the advantage of lasmiditan over triptans? It is safe in what? Is it safe in liver disease, renal disease, vascular disease, or cardiac failures? The advantage of lasmiditan over triptans. In which of the following is it safe? Here are your options, and your time starts now. It is lasmiditan, oh, that is very good. Vascular disease is the right answer. So lasmiditan is a 5-HT1 agonist. Triptans are 5-HT1B and 1D receptor agonists with affinity for the 5-HT1 receptor subtype as well. Triptans cause vasoconstricting effect via the 5-HT1B receptor subtype. 5-HT1 receptor subtype is located in the trigeminal ganglion, the trigeminal nucleus caudalis, and cephalic blood vessels. So activation of this receptor does not constrict blood vessels. So 5-HT1 receptor agonist, that is lasmiditan, is useful, and ditans act selectively on 5-HT1 receptors, so do not cause vasoconstriction. So all those who have answered, 62% of you have answered it rightly. It is useful because it has got no vasoconstrictive effect in vascular disease. Okay. Third last question. Reversible cerebral vasoconstriction syndrome is associated with which of the following condition? Is it associated with the vasoactive drugs, postpartum state, migraine, none of the above, or all of the above? It's a fairly straightforward question, easy question. So use your app and vote now. Easy trick, nahi? When there is all of the above, use all of the above. This is what we have been doing since our UG days. So yes, absolutely right, all of the above. These are various conditions in which RCVS is seen. It is seen in pregnancy when there are changes in estrogen progesterone levels, eclampsia, pre-eclampsia, ovarian stimulation. It is seen with headache disorders, primary thunderclap headaches, primary cough headaches. When vasoconstrictive agents are used, the anti-migraine agents, blood products, when there is RBC transfusions, cough and cold suppressants, antidepressants, illicit drug uses of cocaine, ecstasy, marijuana, and LSDs, chemotherapic agents like tacrolimus and cyclophosphamide. It is also associated with tumors, carcinoids, paragangliomas, pheochromocytomas, and hypercalcemias, porphyrias. It is occasionally seen with vascular diseases like the CVST, cervical artery dissection, neurosurgical manipulation of intracerebral arteries, spinal subdural hematomas, and so on and so forth. So you have to remember when it is associated with changes in estrogen progesterone levels, headache disorders, vasoconstrictive agents, tumors, metabolic, environmental exposure, and vascular causes. Okay, good. The second last question for the quiz. the Gepant, which is US FDA approved for treatment in acute migraine, is Olcigepant, Telcigepant, Ubrogepant, Atogepant. The Gepant, which is US FDA approved for acute migraine, is which one of the following? Go on your voting pads and start voting. Absolutely right. I never knew these answers previously. Only during the course I have realized. So Ubrogepant. The Gepant, which is US FDA approved for acute treatment, is Ubrogepant. It is orally used, has got no liver toxicity. It achieved first and second trials, and 50 to 100 milligram can be given. The others, Olcigepant, it was IV, short half-life. It was the first one which was used, and it has been discontinued. Telcigepant, which is also oral but has got liver toxicity, and so it is discontinued. The Atogepant trial is going on. It is used as a prophylactic. It is in phase 3. The other drug, which is Rimegepant, is the other one FDA approved for acute migraine at a dose of 75 milligram. Its trial as a prophylactic drug is ongoing. So your answer is Ubrogepant, which 61% of you have answered correctly. Good. Gearing up for the last question of the day. Name this sign on the MRI. You can see this. Is it the lambda sign, the delta sign, the venous distension sign, or the Eiffel Tower sign? So name this sign on the MRI. Get ready on your Slido for the last question of this day. Absolutely correct. So it is Eiffel Tower sign, is Eiffel Tower lighted at night actually. So I think Rahul Rajiv has got the maximum number of correct answers in shortest time. So congratulations to Rahul Rajiv. Sir, if you could take over. I would just second is Dhananjay, who's done absolutely well, 22 out of 27. Vikram has got 21 out of 27. So this is absolutely well done, guys. You people have attended the headache modules well. Absolutely brilliant to know. So about this lambda sign, it is seen on images, T1 post contrast images. There is reactivation of, it is classically seen in reactivation of idiopathic hypertrophic pachymeningitis. There is involvement of the FARCs and tentorium with thickened dura, and the differential diagnosis could be anything between an infective, inflammatory, or neoplastic. So well done, guys. This is your score. You have done wonderfully well. So I would like to hand it over to Shripad Pujari sir.